Hi, my name is Kaycee Crist, and I am a student at the University of Michigan School of Nursing. Today I will be giving a full report of my patient, including background data, functional assessment information, a review of systems findings, and physical examination findings. Patient is a 71-year-old Caucasian female. She was a secretary for 43 years and has been retired for 10 years. Her current source of medical care is a primary care physician. The patient's vitals are a respiratory rate of 26, pulse of 86, blood pressure of 130/88, and temperature of 98.4 degrees Fahrenheit. The patient is 5 feet 5 inches tall and weighs 168 pounds. The patient's reason for seeking care is difficulty breathing, along with impaired mobility due to lower extremity pain. The patient began having the most recent bout of difficulty breathing 2 weeks ago. Patient reports that it feels like there is something pulling on her lungs, making them hard to expand, and it just never feels like she's getting enough air in. She reports that the difficulty breathing is constant throughout the day and is worsened by physical activity and laying down flat on her back. Sitting upright alleviates the difficulty a little, and rest and decreased movement are helpful. The patient also has an oxygen tank. To alleviate some of the difficulty breathing, patient lays with her back propped up so that she's not laying flat on her back. Patient reports daily activity is difficult because of the decreased ability to move due to a hyperactive respiratory rate when simply walking around. Symptoms include a deep and heavy breathing after moderate activity and an increased respiratory rate along with fatigue. Patient believes her COPD is worsening. Patient has decreased mobility due to lower extremity pain for the past 10 years. The pain has worsened in the past year. Pain is localized to the knees and the hips, and it is described as dull and achy. The pain is more intense when active, but is still present when stationary. Lots of physical activity and standing upright aggravate the pain, and sitting and resting, along with ice and ibuprofen, alleviate the pain slightly. Patient ices 20 minutes on, 20 minutes off, 2 cycles twice a day, and takes 2 normal-strength Advil tablets every 6 hours to help alleviate the pain. The pain in the lower extremities is very detrimental to daily activities and makes doing almost everything painful, difficult, and unenjoyable. Patient has recently gained weight as a result of the lack of mobility due to the onset of worsening pain a year ago. Patient believes that her arthritis in her knees and hips is worsening as she ages. The patient had chickenpox around the age of 8 and shingles at the age of 50. She has a history of COPD for the past 7 years. She has had diagnosed arthritis in her knees and her hips for 10 years. The patient reports being up to date on all immunizations. She is allergic to latex, nuts, pollen, dogs, and cats. She has no surgeries or hospitalizations. Patient currently takes 1 2-milligram tablet of Latuda for her arthritis, along with 2 normal-strength Advil tablets every 6 hours to help manage the pain. She also takes Spiriva, a long-acting bronchodilator, for COPD. Dosage is 1 capsule or 2 inhalations by mouth of the medication daily. The patient smoked about a half a pack of cigarettes a day for 20 years, and she quit at the age of 40. The patient drinks 1 glass of red wine daily, admitting she knows it's good for her heart. She does not use illegal drugs. She reports decreased activity due to age and medical problems. She said her nutrition is good and that she eats 3 balanced meals a day and is trying to improve her diet even more because of increased sedentary lifestyle. She reports normal rest and wakeful patterns, getting 6 to 7 hours of sleep a night. The patient drinks a decent amount of caffeine, reporting drinking 5 cups of coffee a day. The patient's father died of liver cancer at the age of 60 and also had hypertension. The patient's mother died in a motor vehicle accident at the age of 66 and had a history of COPD and also smoked. Her sister, age 75, had impaired mobility and is currently suffering from Alzheimer's. Her brother, age 69, suffers from COPD. Her brother died at the age of 61 due to lung cancer. He also smoked. The patient's general perception of health is that she is fairly happy with her health due to age and lifestyle choices, but wishes she would have taken better care of herself when she was younger. The patient was alert and responsive and cooperative when asked questions. Review of Systems 1, Respiratory. The patient reports shortness of breath, especially during activity, and the more active, the more labored breathing becomes, and the harder it is to get air into the lungs, according to the patient. Patient reports that the chest wall feels tight and that it is hard to expand lungs all the way. Patient denies major chest pain, but reports it as more of a discomfort. She would rate the pain as a 1 or 2 on a scale of 1 to 10. She reports being able to walk 10 to 20 steps before shortness of breath comes about and breathing becomes difficult. She reports no pneumonia, bronchitis, or asthma in the past. Patient reports a frequent wet cough for the past 2 to 3 weeks. The mucus is thick, wet, and yellowish in color. She reports that she is not coughing up blood. She says it always feels like there's something stuck in her throat that she can't get to come out. She reports that medication previously had helped with breathing before, but now it has become increasingly less effective. She reports being tested for TB in the past and never testing positive, and she has not recently been exposed to anybody who has tested positive for TB. Patient reports absence of a sore throat, changes in voice. She reports no nasal drainage into the throat. Review of Systems 2, musculoskeletal. Patient reports joint pains in the hips and the knees. She reports joints appearing red and feeling warm and are sometimes visibly swollen after walking a lot. Says joints are creaky, especially in the morning. Swelling was reported, but does subside after a day or two of rest and taking ibuprofen. Patient rates pain in the joints as a 3 out of 10 when at rest, but can get up to a 7 out of 10 when active. Patient reports joint stiffness in the morning that decreases throughout the day as the joints warm up. Medication was reported to help the pain, but never completely alleviated it. Recent medication seems to be less effective as the pain has increased over the past year and the pain is in more discomfort. Range of motion in the knees has been greatly affected. Patient reports not being able to bend the knee at a 90-degree angle. Daily activity is greatly affected by joint pain. Once pain is bad enough, she has to stop whatever she is doing and rest, making it difficult to get anything done in a timely manner. Patient reports weakness in both the knees and the hips. She reports she doesn't trust herself to bend at the knee for fear of falling. Arthritis was diagnosed for 10 years and reports that treatment was effective until about 6 months ago. She believes she needs a change in treatment. She has no history of broken bones, dislocations, osteoporosis, or gout. She reports no muscle weakness or tenderness, but sometimes does feel sore. Patient reports decrease in muscle tone due to inactivity. There is no muscle cramping. There is also no history of muscular dystrophy. Physical examination, respiratory system. Patient's chest is of a normal color with pink undertones and no cyanosis, pallor, or jaundice. The AP transverse diameter is 1 to 2, with no injuries or deformities. Both sides of the chest are symmetrical. Breathing pattern was disturbed. Patient is in slight distress and breathing looks labored. Respiratory rate is hyperactive and the breaths are shallow. Trachea was palpated and is midline with no palpable deformities. Posteriorly, the lungs expand equally. There is no palpable tactile ephemeris. The ribs and thorax were palpated posteriorly and there were no abnormalities found. Upon auscultation of the lungs, wheezing and rhonchi were heard. Rhonchi, which is a coarse and rattling sound, was heard in the upper lungs, while wheezing, which is a whistling or rattling sound, was heard in the lower lungs. Bronchophony, egophony, and whisper pectoriloquy were performed, and no abnormal findings were found. Physical exam, musculoskeletal. Patient's bone structure is normal, and bones are present and standing how they should. The patient looks muscular and not frail, like she would blow away in the wind. She also does not appear to be just skin and bones. The patient has an appropriate posture and is sitting and standing upright without help. Patient has a slow and awkward gait and appears to be in pain when walking. Patient was assessed for scoliosis in the spine, was in line and midline without any curvatures. The TMJ, neck, shoulders, elbows, wrists, fingers, and ankles were all tested for full range of motion. There was no redness, inflammation, warmth, or crepitus in any of these joints. Patient also reported no pain during the range of motion evaluation, and all joints had a full range of motion. The hips were assessed for full range of motion. Patient did not have full range of flexion. She could not bend the hip to 90 degrees, or hyperextension, meaning she could not pull the hip beyond 180 degrees. She could also not circumduct her hips. Abduction and adduction were intact. There was pain rated at a 5 during the range of motion test. There was audible crepitus during the examination. There was no present swelling, redness, or warmth to the touch of this joint. The knee was assessed for full range of motion. Patient was unable to extend the knee to a full 180 degrees and was also unable to flex the knee further than a 90-degree angle. Pain was rated at a 4 out of 10 during the examination. There was audible crepitus during the range of motion activity. When palpated, the joint felt inflamed and was warm to the touch. The knee was also a little red. When muscle strength was tested, deltoids, biceps, triceps, wrist, ankles, and fingers were all graded at a 5 out of 5. Hip adductors and adductors were rated at a 4 out of 5, and the hamstrings and quads were graded at a 3 out of 5. Additionally, it would be wise to check the cardiovascular system because of the patient's COPD. According to S. Agony, many of the high-risk comorbidities for COPD are cardiac in nature, including cardiac arrhythmia and congestive heart failure. Since these two conditions are major and life-threatening, it is important to check them since patients with COPD are at heightened risk for them. It is always necessary to take extra precautions against potentially fatal comorbidities when we know that they are likely. In addition, it would also be wise to do an HEENT exam, in particular looking at the eyes. According to L. Tong, the same pathophysiological agent that attacks the collagen causing arthritis in the joints can also attack the sclera in the cornea of the eye, which also contain collagen. In this exam, we would be looking for impaired tissue integrity, including dryness, swelling, and clouding in these structures. This is the end of my patient examination, and here are the references for my articles.